Good afternoon, everyone. I know we're all kind of tired, but thank you for coming to the session called Bending the Curve, Modernizing HIV Prevention Through Balanced Curation of Interventions. My name is Solange Batiste. I'm the Executive Director of the International Treatment Preparedness Coalition, ITPC, and I am a treatment activist, and I'm leading this session on prevention, which I think is the very point for all of us to come together and really discuss how we can bend the curve. So we're going to jump right in and introduce MK Go to the stage, to the podium. MK is the Chief Executive Officer of Carex Malaysia, which is the world's largest condom maker. So I could essentially say, if you want to know anything about condoms, we can ask him. Also, they provide products to a diverse range of customers around the world, but also collaborate with organizations like the United Nations, UNAIDS, World Health Organization, and other government bodies. So welcome you to the stage. Thank you.
Well, good afternoon, ladies and gentlemen. Condoms have played a major role in the global fight against HIV/AIDS. For decades, billions of condoms has been procured by governments and institutions around the world to be either given out for free or to be sold at highly subsidized prices. Condoms have come a long way since it was first developed, and the first male rubber condom was invented in 1855. And for a product that's 163 years old, unfortunately, the look and feel of this product remains relatively similar from the day it was invented. However, we have seen huge improvements in the last 20 years in terms of the quality and the reliability of the male latex condoms. And that is really much thanks to the International Standards Organization and as well as regulators in around the world to ensure that condom quality is always good. The challenge back then was to produce a product that is reliable and also free from holes and also breaking during use. Well, thank God we don't hear that much anymore today. The challenge we today see is more about the fact that condoms are not providing enough pleasure. And as a condom maker, we need to focus on innovation today. The distinguished Bill and Melinda Gates Foundation put a call in 2013 to find the world's next generation condom, echoing opinions that the condom in the current form represented an outdated technology and that while effective, it did not entice users to use it in their daily lives. A batch of winners were chosen from the submission and were given initial trials. Grants, however, is now over 5 years and not a single submission has attained commercial viability. Although many of these ideas incorporated great ideas from new methods of application and new technology and new materials, they were unable to overcome the regulatory requirements to market those medical devices. In many ways, the condom industry struggles to balance innovation with regulations. Regulations has undoubtedly played their role in ensuring the quality of condoms that are unquestionable today. However, worrying statistics shows that only 5% of men worldwide are estimated to use them. This speaks to the fact that while safe, simple facts that the majority of the public still do not favor condom use. Well, maybe I'll give you a little bit of my experience. And, working in a condom company, and we still, today, I believe we live in a world that we believe that it's still a one-size-fits-all product. But I'm sure many people out there would dispute it. And many times, we even say that a condom fits a watermelon. But how many times do we ever ask the watermelon if it feels comfortable? Industry experts and data tells us that the one-size-fits condom fits only 12% of men comfortably. And no wonder when I read or see a survey, 80% of men usually complains about condom comfortability. And in my company, we launched a product last year with over 66 sizes that caters 95% of all male penises sizes. But let me tell you, the regulatory process took us over 20 years to get that included in the global ISO standard. Well, if we are to get prevention back on track, we desperately need to modernize our approach to HIV prevention. Condom innovation as a whole, from regulators through to manufacturers and brand owners alike. We must encourage to make condoms more enjoyable and acceptable for the users. Budget allocation is today one of the major obstacles I face in my daily work. And while it's important to seek a cure and provide treatment, let us not forget that this battle is far from over. We need to ensure that budget allocation towards prevention, towards purchases of condoms, will have to continue to ensure our 2030 budgets. It's sad to say that sometimes in many of my work right now, we do see that there is a lot of countries that currently are running into budget allocation, and I foresee that in years to come, there will be many condom projects around the world that will cease to provide condoms to the public. And with that, we think there could be a potential reversal. And I think we are also starting to see countries where HIV/AIDS is starting to move upwards, as well as in my country, in Malaysia. We are one of the top 10 Asian countries where HIV/AIDS is starting to come back. And that's many due to the fact of the spread from the sexual context. So finally, I must iterate my opinion that there is an urgent need to change our mindset about how we are combating HIV/AIDS today. The way funding and regulations has evolved over the years has served a purpose in getting us to where we are today. But if we fail to realize the need to innovate and modernize our thinking, all that has been done so far stands to be lost. Thank you very much.
Hello? Yeah. Thank you very much, MK. The idea here, we have a packed agenda today, is to bring different perspectives because we're looking at what does that balanced curation of interventions look like, right? No one disagrees that we need to reduce incidence and reverse it in many regions such as Eastern Europe and Central Asia, the Middle East and North Africa. But what does that balance look like given limited funds and limited investments? And so we have many different perspectives today, from donors to implementers, and the manufacturer, which we just heard is also one that we often leave out, researchers and communities. So with no further ado, I'm going to introduce Casper as he makes his way to the podium. Casper is a desert dweller. He's lived 20 years in Namibia. He was the executive director of Positive Vibes Trust in the SADC region and is now the head of influence at the International HIV/AIDS Alliance. Casper?
Yeah, thank you very much. I think I have to start by saying that yesterday evening we ran a prevention session that was full of advocates and that there was a lot of excitement in the room. And at the end of the day, we were really congratulating ourselves on how much excitement and hype there now was at AIDS 2018 around HIV prevention. Looking around the room this morning, that's hard to see perhaps. But I hope those of you who are here really generally care and want to push this agenda forward because it really is important. Having said that, my brief is to frame this session, which looks at modernizing the modernization of HIV prevention by a balanced curation. In doing so, I want to start off by doing a quick reflection about the road that we've walked together towards our present prevention predicament. To date, an estimated 76 million people were or are currently living with HIV. That's an enormous amount of people. In fact, I don't think that there are many of us in this room who have not been affected directly or indirectly by the epidemic. such has been its impact. In my adopted country of Namibia, I remember when we had a region where up to 43% of pregnant women tested positive during the early 2000s. In other words, a young girl's lifetime risk of contracting HIV was somewhere between certain and guaranteed. In the pre-treatment days, the tools at our disposal to respond to HIV were rudimentary, yet I think we pursued them with zeal and with passion. Often the front line of the response was the community, where people were mobilized to disseminate essential information and commodities like condoms and lubricants, but also pushing social and cultural boundaries in order to shape the way for a public health response. It was a time of innovation and drive that saw a lasting fusing of public health and human rights thinking, which gave birth to powerful concepts such as PHDP, positive health, dignity and prevention. Where's that gone? And combination prevention. And as depicted here, these efforts did bear fruit. The first time the incidence curve was truly bent was back in the mid to late 90s and again in the early 2000s, as you can see in the red line there, the red graph. Of course, there was a so-called maturing of the epidemic, but incidence had in fact been in steady decline since about 2001, or has in fact been in steady decline since 2001, which is quite a while before the effects of life-saving treatment started to have an impact, as you can see. The point I'm making is that primary prevention was and remains effective. The fact that we now have U equals U in our prevention toolkit, I think makes the next slide all the more puzzling. The latest UNAIDS data shows that since 2010, new HIV infections among adults have declined by an estimated 16%, from 1.9 million to 1.6 million in 2017, which is far away from reaching a 75% reduction by 2020. As is being mentioned very often at this conference so far, there's less than 600 days until we're supposed to meet the 2020 targets, a target that over the previous 2,800 days we have barely made a dent to. And we appear unlikely to achieve it, which is why we are now openly talking about a prevention crisis. The biggest question is, how has this happened? How? As repeatedly stated by UNAIDS in their GAP report, and even in the famous armamentarium report of the Lancet Commission, we have the tools and we know that they work. So how did we end here? I think the safe explanation that's often being used is that there is a population bulge, which has increased the number of people at risk. And this is undoubtedly true. However, a harder truth to face is that many primary prevention programs have suffered from a trio of factors. They've been weak or scattered and of insufficient scale to truly have an impact. Few things illustrate this as clearly as this slide that was presented by Henk van Rentegem from UNAIDS on Monday during this conference, which shows the tragic collapse of condom programs in 35 countries across the world. If you see the green on the left-hand side, you can see where scaling did take place, but you can also see that in almost all those countries, there's a downward trend. And that downward trend you can see across the different spectrums here, from the countries that were lagging, from the countries that really rarely got off the ground, and the ones where everything has failed. So we're not in a good state when it comes to condom programming, which is why it's one of the things that I've been shouting from the rooftops at this event. To finish off my framing, I'm going to take a moment to state the obvious. If we want to end new infections, we have to make targeted investments to do so. Again, according to UNAIDS, 44% of all new infections occur amongst key populations and their sexual partners. Even in so-called generalized epidemics, key populations are disproportionately affected. Why is that? For one, sex workers, men who have sex with men, drug users, and the transgender community have multiple interacting layers of barriers to get through before they can access safe and relevant services. We also cannot ignore the impact that structural barriers have on adolescent girls and young women. another demographic with extreme risks in regions such as Eastern and Southern Africa. To reach our target, it seems obvious, therefore, that we must pursue real efforts to remove structural barriers to access, and that by whatever means possible, we provide services to those who are most marginalized and those who have the highest chances of contracting HIV. If the last 8 years have taught us anything, it's that half measures only get you halfway. And in this case, you would argue even less. When it comes to prevention, I would argue that we're not on the last mile, we've only just covered the first mile. Lastly, if you're interested in knowing more about where we are with the current prevention efforts, the Alliance has produced a series of shadow scorecards in relation to the global targets that track progress and gaps. These will soon be uploaded on our website, which you can see there, alliance.org. It shows shocking statistics like the rising incidence curve in Ukraine. Surely that's not what we had in mind when we meant bending the curve. So with that being said, I thank you very much.
Thank you very much, Casper. We'll now move to Gino, and thank you for that framing. So we go straight into Gino Dalla, who is a senior program officer at the Bill and Melinda Gates Foundation and has been working in HIV since 1989. Her focus has been on prevention and particular issues around implementation of scaled programs. And Gino is going to talk to us about why prevention programs succeed or fail.
Good afternoon. Thanks for being here. I'm going to be talking mainly about examples of programs that have succeeded and trying to tease out those elements that look like they've contributed to success. And I've specifically chosen older programs where our toolbox was limited to almost illustrate the point that it's not the tool, it's the program that makes the difference. I don't need to reframe what was just talked about. Incidence and mortality are going down, but due to the success of scaling up of treatment, PMTCT, and variable efforts at prevention globally. But the total number of cases are going up because we have rising infections in populations that don't have access to services or are systematically marginalized or have stigma against them because of their behaviors. So what can we learn from successful prevention programs? And I show here a slide of Cambodia that successfully scaled its prevention program starting in the early 90s. And I just wanted to illustrate that they bent the curve to prevention long before antiretroviral therapy was made available. And this was really done through scaling of programs for particularly sex workers in the country. What were the elements that made Cambodia successful? Well, they really understood their epidemic. They understood that it was fueled by sex workers and their partners. They collected data to inform how they were doing. If you look along the bottom, you'll see a lot of arrows around various surveys that were done to collect the data. There was government ownership of the program. The government looked at the data, directed plans towards addressing the problem, and there was the involvement of civil society, although I would say probably not as strong as it is now because we've learned how to do that. They understood where the problem was and had, as I said, frequent assessment of outcomes. There was really a multi-sectoral response managed under the National AIDS Control Program, and they did have some structural interventions around 100% condom brothels. The second example is a little snapshot of Australia. This is between 1999 and 2000, but Australia implemented very early on a needle exchange program, harm reduction for drug users. They started early in the 1980s, even before harm reduction was really promoted as an intervention tool. It involved a lot of collaboration between civil society and public sector, and the government funded the program. They supported free needle exchange programs in 800 sites, subsidized the purchase of needles in 3,000 pharmacies, and had over 100 vending machines across the country. The upper slide here shows you that they've kept their injecting drug use epidemic low. They didn't do so well on MSM, but the simple implementation of needle exchange programs in Australia early on kept that epidemic from growing. My third example is Zimbabwe. And again, Zimbabwe instituted a lot of behavior change interventions and condom programming and condom social marketing. And you can see even before antiretroviral therapy came in the mid-2000s, they had really turned around their curve, which was correlated with an increase in condom distribution. Again, there was government ownership of this program. There was a strong health system and community response in Zimbabwe. They had antenatal clinic data as their monitoring tool from the 1990s. Again, a multi-sectoral response, high coverage of behavior change and media, and as I pointed out, widespread distribution of the one prevention tool that existed, which was condoms. The fourth example is India, and this is more recent. India has a nationwide key population program and has been able to document continuing declines in HIV prevalence in MSM and sex workers. And the injecting drug users, I think, are a little bit more problematic for them, and they've just begun to address transgender separate from men who have sex with men. Again, India owns its program. Its national strategic plans from the second strategic plan have highlighted key populations as the target population that needs to be addressed. They have the largest social contracting mechanism that I've seen for key populations. They started in the cities, expanded to the highest prevalent states, and then expanded nationwide. It's implemented by civil society, but monitored by government. And they have a well-defined comprehensive service package that defines what you're supposed to give, how frequently, the intensity, and they have ongoing data for decision-making, both surveys and regular program monitoring. So they're able to adjust the program based on the data, and they fund the strategic plan. The final example I want to give you is really PrEP in San Francisco. This is not a scaled program in the sense that it's not national, but it is an example of where a program that has long-standing ties to the communities and a lot of community mobilization was able to roll PrEP out fairly easily once it started. They understood what the barriers were to PrEP and addressed those as part of the program. The term here is full navigation benefits, what was really helping people go through the paperwork of getting government or insurance to pay for it. And they were able to get people on PrEP and retained on PrEP and show a marked reduction in incidence, and those people were on PrEP over 16 months. So four of the five examples I've shown here were in key populations. And we do, and in the world, have a lot of experience with key populations and understand how to do it better, understand how to involve the community better, understand all the kinds of things we need to do to reach these populations. And we did this with a very limited toolkit, which is really needles and syringes and condoms. We now have a much broader toolkit. We have treatment, we have PrEP, and we have the old tools also, opioid substitution therapy, needles, syringes, exchange, and condoms. So for key populations, there's no question of what or even how to do these programs. It's really an issue of political will, reduction of stigma, and funding. I would say that for the other groups that appear to be left behind, the adolescent girls and young women and their partners and young men, there's really limited evidence of scale, of successful programs of scale, and we're just starting those and needing to learn how to do those. And investments are going towards those now. I think our collective failure in prevention is not tool-related, it's program-related. So we need to start thinking about the programmatic issues of implementing prevention. They're the same issues of implementing treatment. You need access to the population, you need their trust, you need, especially for these marginalized ones, working with them to reach the population. That's both prevention and treatment. As has always been said, there's no magic bullet, and it has been pointed out at this conference, there have been over 20 presentations on PrEP. There was one session on condoms that was paid for, and there was no session on voluntary medical male circumcision. There's been a lot of presentations on key populations and adolescent girls, which is great, and on men, but I think we need to sort of get away from the magic bullet assumption that one thing's going to make it work. We have to really address the multi-layer, complex, difficult, and mundane issues of implementation. And I'm not going to read this whole list here because you know all of them, but the key issues seem to be issues around access platforms, key population programs actually go out and find the individuals and create NGOs, safe spaces, specific access platforms for them. I don't think we understand how to do that for adolescents yet, although schools are probably an existing structural platform that we can use to reach them. And then we'll see if men can be convinced to come into existing services or how much we have to address a platform to reach them. Thank you very much.
Thank you very much, Gino. Those are some alarming things that you've raised. And I think it flows really well into our next speaker, Robert Grant, who will be talking to us about PrEP and the importance of community involvement in the age of U equals U. Robert is a professor of medicine at the University of California, and he has led the IPREC studies that first showed that daily oral PrEP was safe and effective for HIV prevention, and then showed that PrEP uptake and use could be high. Over to you, Robert.
Thank you very much for this opportunity to talk about what I think is a new way that we can address unmet challenges on the road to ending HIV/AIDS. We do have technology, and some of it is powerful if we know how to use it. But yet, to really get to the end of HIV transmission and AIDS disease, we need to find ways to reduce stigma, have more inclusion and diversity in our programming, increase HIV testing, increase uptake of PrEP and ART and condoms, increase access to services, and achieve full funding. What I'd like to argue in the next 8 minutes is that these are all social processes, and the social theory of practice, which is just emerging to be applied to public health, can help us identify how these problems arise and how we can shift our practices toward desired outcomes. I think too often at this meeting we lament that it's either human nature or structural problems which drive these underlying determinants of the HIV epidemic, and that in the end it's overwhelming for any one of us to know what to do about them. The beauty of the social theory of practice is it really does embed and help us understand how each one of us is embedded as an agent in these social processes, and that gives opportunities for change. One opportunity for change is for me to encourage all of you to attend the pre-conference next session, in 2 years, of the Association of Social Sciences and Humanities in HIV, or ASH. This is held in conjunction with this conference, and it's full of interesting sociology, anthropology, and social theory that really includes many ideas about how we can address these daunting problems. First, I'd like to say that even though human behavior is sometimes regarded to be intractable and based on human nature that's immutable, in fact, we see on an ongoing basis examples of how human behavior changes in massive ways in movements, and that this has been possible in relation to HIV/AIDS as well. And if we think of successful social movements that have had an impact on HIV incidence, we think of examples like condom use, which spread quickly in MSM communities in the early 1980s, the Love Carefully movement in Uganda in the late 1980s and 90s, seroadaptive practices in the late 1990s, PrEP among gay men in 2013 and beyond in the United States and now other countries like Australia. And we're just starting to see the impact of U equals U as a social movement. These are all these success stories of massive scaled changes in human behavior have several common characteristics. One is that technology is often involved but is not sufficient. Second, these really start as grassroots initiatives, then leading to mobilization. It involves person-to-person connections, often with activists and community educators like many of you in the audience. These movements have all affirmed sexual and social goals, and they have all required reinvention on an ongoing basis to stay on track and to avoid a solution today from becoming part of the problem tomorrow. So I wanted to describe specifically ways in which PrEP and the U equals U practices share social manifestations and really have a lot in common. Both decrease fear of HIV in people living with HIV. Both endorse and advocate for safer and more pleasurable sex. Both inspire vehement controversy, probably because of the two bullet points above. Both start with an HIV test. Both involve taking and trusting antiretroviral therapy. And so given all these commonalities, while professional providers sometimes see PrEP and treatment as different or even competing projects, communities and community members often embrace these commonalities and see that this is really part of a common diversified movement. And I wanted to focus on stigma because I think at root this is one of our core underlying problems. And both PrEP and U=U as movements, I believe, disrupt stigma. And they do it in part by bridging the serological divide. To understand the serologic divide, you need to understand seroadaptive behaviors. These were sexual practices based on the serostatus of partners that emerged in the 1990s. And they emerged in gay communities in the United States, but they were also quite evident in several African populations. Serosorting is the extreme seroadaptive behavior in which sexual partners are chosen and based on their serostatus, and partners with a different serostatus are excluded from the sexual network. So there's seropositive serosorting and seronegative serosorting. Unfortunately, this practice, which did become widespread and continues today, tends to breed ignorance, fear, and stigma in the serologic divide because people are no longer getting to know each other. They're no longer sleeping with each other. And PrEP use and U=U enable sexual and social bridges across this serologic divide. And these bridges, we believe, are building trust and community. After all, pillow talk is a powerful communication practice that's often trusted. So as these serologic divides are regressing in the face of PrEP and U=U, we're seeing new divides appearing based on whether viral load is detectable or not, and whether someone has access to and is using PrEP. And these new divides are particularly powerful, and I think could potentially run deep, because they reinforce stigma that already arise from unequal access to income, healthcare, and information. So I wanted to focus on stigma because I think that this is something that we see disappear in one moment and then reappear in another. And this is an insight from the field of psychiatry, which I thought was particularly helpful. Psychiatrists working with people with mental illness know a lot about stigma. Their patients are stigmatized, and they as providers are often stigmatized in association. And this argument, made by Griffith and Cornt and Smith, argues that stigma is an affliction of normal people and normal brains. And the idea here is that stigma starts with othering, which often occurs with charitable intent. People say, well, I have privilege and power, I'm going to help them who have needs. And so it can start with charitable intent, but it starts with the notion that there's a them and there's an us. And this othering breaks down the conversation. And so they've argued from their clinical practice and research in psychiatry that the goal of stigma management is to move from these categorical processes to person-to-person relatedness. And what this means is very literally personal interaction, eye-to-eye conversation, and sharing vulnerabilities, seeing the other as a person and not just a member of a group. So this leads me to one of my first insights from my own practice, is that the most powerful stigma intervention is to listen and speak to each other. And I learned this perhaps the hard way in Cambodia when I was proposing PrEP research there, and needed to have several difficult conversations with sex workers, and who said that they were primarily concerned about gender-based violence and not HIV at the time. And this is the kind of conversation that, in fact, was most useful, a heartfelt, difficult conversation, eye to eye, with someone who was passionate, who didn't agree with me, and I realized that my role, my job, was to listen to her, and her job was to speak her truth. and that this really, this kind of connection is essential for bridging across stigma, and there's no mass way to do this. It's really one-on-one, small groups, eye to eye. So I think that there's several other underutilized HIV stigma interventions. I think U equals U is an important one. We should be saying that having an undetectable viral load leads to untransmissible virus, because this decreases fear of people living with HIV. I think we need to offer PrEP to decrease fear of people living with HIV, antiretroviral medications, and HIV testing. We need to eschew othering language. And I would point out that the McCarthy-era phrase risk to the state was the first time in the English language that the word risk was used to refer to people rather than situations. Up until the 1950s, risk referred only to situations that people had to become courageous and heroic to overcome. It was in the 1950s that the person themselves became the risk to the state. Unfortunately, the HIV industry picked up this McCarthyian use of the word risk and embodied it in terms of risk groups. It's not an evidence-based concept. Our analysis of temporal variation in sexual practices has clarified that identification of high-risk people is not very helpful. Rather, it's more important to identify high-risk moments and situations that cause them. I'd like to end with the notion that we need a new sexual health lexicon. We tend to use stigmatizing words that are othering. We talk about them, their needs, high-risk people, risk behavior, targeting them, discordant couples, adherence. All of these comments, all of these phrases, some of them used with charitable intent, imply that there's an us who's all-knowing and powerful, and a them who needs us. We don't have to speak this way. We can use inclusive words. We can talk about us, our desires, popular and affectionate people, pleasurable sex, mobilizing rather than targeting, couples whose love is greater than HIV, and use of medications rather than adherence to our recommendations. I don't think I have time to talk about this much, but as we move forward, it's important to realize that these technologies that we have, be they PrEP or U equals U, can be deployed in favorable ways or in disfavorable ways, and the inputs of communities and our attention to our social practices around inclusion will make the difference. Just wanted to leave with some notions that what we're calling for, the end of stigma, is really an insight that comes from several traditions. Mother Teresa said, if we have no peace, it is because we have forgotten that we belong to each other. And then there's the Ubuntu concept, which translates, I am because we are. Notice how strikingly different that is from the Cartesian notion of I am, I think, therefore I am. This is I am because we are. So what do we do now? I think we celebrate U equals U and offer PrEP. We be curious about these as evolving social practices which we enact and shape. We drive the change that we desire in these practices. We practice inclusion by using inclusive words, and we speak and listen with someone who frightens us. These are the ways that we bridge and build our communities, and this is the way we end the HIV epidemic. Thank you.
Thank you so very much, Robert, for some very thoughtful comments. We're going to move now into implementation challenges and opportunities by Dr. Wanjiru Mukoma. She's the executive director of an organization called LVCT. It's a Kenyan NGO, and she has a background in psychiatry and mental health from the University of Cape Town. Her organization works to reduce new infections and increase access to equitable access to health services. Wanjiru?
Thank you, Solange. Good afternoon. I have no conflict of interest to declare. I am Kenyan and not conflicted about that. So I am part of Team Kenya. So I was invited today to speak from a service provider perspective. As Solange has said, that I work at LVCT Health, an organization that delivers HIV services and programs in Kenya. And HIV prevention for key populations is one of our biggest programs, and we're one of the biggest providers of those services in Kenya. So I'm going to be drawing my talk from my experiences at LVCT Health and from Kenya. I'll skip this slide. It's stating the obvious, and it's been said. and go to this one just to say that the treatment cascade is much more advanced than HIV prevention cascades is. I know there are conversations around that, but I don't provide this for a comparison of treatment and prevention, but it really just to provide the background for some of the thoughts that I want to share in my presentation. For prevention, we've heard even in these previous presentations about combination prevention, which is the approach that we have been using. And basically, this is what it looks like at a service delivery level. It's biomedical, structural, and behavioral interventions. And we think of this very much from a service delivery perspective and the services that we are delivering. But I'd like to invite us to think that maybe there are other combination preventions that we could be thinking about beyond this that will support even the biomedical interventions we want to implement. We could have prevention combination of stigma reduction, advocacy, and decriminalization, or some of what the previous speaker has spoken about, respect and PrEP and gender equality and dignity, or other combinations that don't render themselves very neatly into boxes that fit into service delivery sites. So I think that maybe we need to extend this concept a little bit further and start thinking beyond just delivering services in a service delivery site to combination interventions in other spheres that are critical for HIV prevention to happen. So I'll leave that there and actually go back to the more conventional biomedical prevention. And I'm going to use this basic differentiated service delivery model just to illustrate some of the implementation challenges that I want to share. So this is how we implement differentiated services in many of our HIV programs. It's about delivering services that are prescribed by the national guidelines in the spaces that are designated for service delivery to reach different populations. And we offer basic packages as prescribed in our national guidelines, and these are delivered primarily by clinicians as well as peers and community health workers. And this looks pretty straightforward. So I think the question is, why is it not getting us where we want to go, and why is it not getting us there fast enough? I'm going to just highlight a few challenges. I'm sure we could add to many more of these challenges. But just to say that the first big challenge for key populations in particular is stigma. But similarly, for adolescent girls and young women, when they go to public health facilities, they also face stigma and discrimination and provider attitudes that deter them from accessing services in a way that they ought to be accessing them. And primary prevention, really, if you're going to implement it in such a model that is a differentiated services, we have to be able to deliver the services in a manner that people want them and to improve access and availability in the spaces where they want those services to be. So this is a model of how we have implemented, apologies for that, you can see up there, for how we have implemented a differentiated model for key populations in Kenya and in LVCT where I work. So that's the basic package of services as required by the national government. And to that, we have added other additional services through a site, a model where they come to a facility or outreach. But even with this, we are not really achieving what we want to achieve with our prevention for key populations. And in the bubble there, it says in Kenya, for example, only 21.5% of sexual minorities visit a healthcare provider when they have a sexual and reproductive health problem. So people are not coming to the facilities as much as they ought to, and even when we take them to outreach, we are not reaching everyone. So what could we do with this model differently? And what are the challenges that we have seen implementing this model? I think one of the challenges we have is providing services when people want them and how they want them. We tend to follow the guidelines, as they say. For example, in Kenya, there's standard application of guidelines where key populations are required to come for retesting every 3 months. And providers apply this faithfully because this is how we are training providers to apply the guidelines. So they are not paying much attention to the differentiated needs of individuals and adjusting the services as they should. And there are a number of reasons why that's complicated. It's also the volumes of work. In Kenya, for example, for one client, you have to fill about 36 toolkits. Some are donors, some are government, some are internal. So there is a huge volume of work that has to be done. So the other challenge is prevention is intensive. and it's sometimes out of sync with people's lifestyles. In ART, we are trying to minimize clinician-patient interaction by giving longer-term appointments and so on. Prevention is intensive. People have to interact a lot more. And when I say out of sync, I'll give an example. For example, in dreams, young women are expected to come to safe spaces on a weekly basis. That is completely out of sync with the reality of the lives of many young women in Kenya, and I'm sure in other places, because they are busy fending for their children, looking for jobs, doing the jobs, and so on. And so the expectation that they would come to a safe space every week is a bit out of sync with their reality. And so we need to be able to provide the services that are in sync with people's lives. People do not come to facilities for prevention, but for biomedical services. And yet, we are loading a lot of prevention interventions into service delivery sites. Even interventions that could be better delivered outside of these service delivery sites. So I think that one of the challenges is that these biomedical sites, we are turning them to deliver everything that we possibly can when the person is there. And we ought to be thinking about how to do better quality biomedical services in these service delivery sites, and then how we synergize with other spaces where some of these services can be delivered better, like community-led interventions, many of which are underfunded, and have weak synergies with the service delivery sites. Within the health system, there's weak synergy, and there's weak synergy from the health system to other health systems. I think we heard on the plenary this morning that we're not going to be able to win this battle if we just focus on health systems. We have to be able to synergize with other interventions in other spaces. For example, for young women or adolescents with the education system, they are in schools, so we need to be able to reach them with primary interventions such as comprehensive sexuality education when they are in schools and not necessarily within the health system. A lot of these services are also supply rather than demand-driven. At national level, there is weak or no clear leadership for national prevention programs. In one of the plenaries this week, one speaker said, if you ask in many national programs who is in charge of treatment, you'll have someone. But if you ask who is in charge of prevention, you'll probably be sent to several different people. And this affects implementation because even us as implementers, sometimes we're getting different messaging from different people at national program and even different programs from the donors that fund our programs. Individuals' prevention needs change. If you are on ART, you are going to be on ART for life. You're going to have to adhere to the ART. When key populations come to our facilities, their prevention needs are changing. And so when we do what Bob said earlier, for example, do risk assessments in the beginning, when someone comes in 3 months' time, their prevention needs is probably very different from what they had when they first came into contact with us. And our services have to be able to respond to these changing prevention needs. We're also very focused on number targets. Again, if I can draw an example from the DREAMS program that we are implementing, we are required to report number of girls or number of women or number of condoms or number on PrEP and those kinds of indicators. Whereas when I go to the field, some of the stories I hear is, I was telling one of the panelists one of the stories I heard about a young woman who told me when she started coming to the DREAMS program, she didn't really care about herself. She said, I didn't even wear a bra. I just didn't dress well. I didn't care. But since I've been in this program, she's like, look at me. I wear lipstick, I dress well, I have self-esteem. And we've had stories of even men who have come to us to say we've over-empowered their women. But a lot of these stories are not measured or reported in the reports that we give. And I think Bob has very well articulated the issue around focusing on risk, both the power it has as language and what it does in terms of entry into programs where we should actually be looking at focusing on positive life and desires rather than just risk. So what are the opportunities? I think there are opportunities in actualizing the prevention coalition roadmap for prevention. I know that there are also discussions on developing prevention cascades. I think these cascades can learn a lot from experiences from the field and the programs that are happening in the field and not just focus on biomedicalizing prevention and interventions such as PrEP that we have heard a lot about. The differentiated service delivery approach is a model that offers opportunity, and the universal health coverage. I'm a bit worried when I heard someone from WHO saying UHC is the way we are going, because for key populations and prevention, it's not going to answer, fill the gaps that we have. And so we need to include it, but we need to also be conscious that it will not be the magic bullet that answers all the questions. And of course, funding community systems and innovations has been spoken a lot about in this conference. I think just to end by saying that the prevention of new interventions won't be won in clinics. We must get the prevention services out to where people meet, where they congregate, how they and deliver these services, how they prefer them, and feed them into their daily lives, and understand and respond to people's greatest prevention needs. Thank you very much.
So, thank you so very much. In the interest of time, we're just going to go straight to Anjali Atreka. Anjali is going to bring us PEPFAR's perspective. She is the acting principal deputy coordinator at the State Department's Office of the U.S. Global AIDS Coordinator, and she is on day-to-day management and implementation of the $80 billion from PEPFAR, which operates, as we know, in 50 countries. So it will be very interesting to hear PEPFAR's perspective, and she's here to talk to us from new prevention, from dream to reality.
Great. Thank you so much. It's a real privilege to be here to speak on behalf of the U.S. government's President's Emergency Plan for AIDS Relief, and to talk, as Solange mentioned, specifically about our response to adolescent girls and young women. Before I start, though, I do want to note that PEPFAR's investment, while it's $6 billion US dollars a year, about $1.5 billion, or 25%, is in fact focused on prevention. So I'm only going to talk specifically about the adolescent girls and young women's piece, but note that we are investing significantly in other types of prevention efforts. So I wanted to start, though, by talking about how we are using data to drive program and to really target our investment. And I think, Casper, you mentioned a lot of this in your talk. That is really critical to our program overall. So we, too, when Ambassador Birx came in 2014, we looked very closely at the demographic population, the trends that were occurring. We noted that in Africa in particular, there was a true doubling of the youth population from those that are aged 15 to 24. That was particularly concerning for us, as these young people are also getting into their most potentially risky experiences with HIV. This particular graph here displays the youth wave in Zambia. So you could see there at the beginning of the epidemic what the population pyramid looked like for the 15 to 24-year-olds, and then you see on the right what's occurring to date with that doubling of the youth population. Recent data that we've released as of yesterday, including the population health surveys that have come out of Namibia, but this is a reflection of the data from Eswatini. So again, these are population-based surveys, and what we're seeing is truly encouraging results. You'll see there on the left that viral load suppression is more than doubling across the overall population from 18 to 49 years, rather. So, which is incredible. We're having HIV incidence decreased by 44% among that same age cohort. So while overall incidence decreases, and we're seeing some positive trends, what's striking here is what we see time and time again when we start looking at the age and sex disaggregation, and this is looking at the 15 to 24-year-old cohort, the 15 to 49-year-old cohort, and then above 15, both male and female in total. And what you see across the board is that the incidence is double among the females than it is among the males, and that's particularly striking. Really, if you turn your attention to the left side of that chart with the 15 to 24-year-olds. When you look at Malawi, and again, this is another example of one of these surveys, you see here, as you go across the age cohorts, you see that among the adolescent and young people, between the 15 to 19, 20 to 24, and on, you see a real spiking of the HIV prevalence, particularly among the females over their male counterparts. What we know from these data and from a number of other data sources is that young women experience an elevated risk for HIV infection compared to their male counterparts. What we've seen from similar FIAs, again, 5 times greater in Zimbabwe, for example, 8 times greater in Malawi, 14 times greater in Zambia. So we were, again, looking at age and sex disaggregated data and particularly concerned. I'll just reflect for a second, because I was in looking at the data from South Africa that they released this week. And I think what they reported here at IAS this week is that among the new infections in South Africa, about 66,000 of the new infections are occurring with adolescent girls and young women, as opposed to 22 new infections among their male counterparts. Again, that's really a significant area. That points to a significant area that we need to focus in on. We also have been working with a number of different countries over the years to support and implement, with the help of the Centers for Disease and Control and Prevention, these violence against children surveys. What we're seeing across the board in a number of countries is the percentage of 13 to 24-year-old female respondents who experienced first sex as forced or coerced is really, really significant. For instance, we're seeing ranges from, this percentage ranges from a low of 11.5%, but to a high of 54.4%. Again, of young women reporting their first experience of sex as forced or coerced. Also, sexual violence among the same cohort, 13 to 24-year-old female respondents within the past 12 months is quite stark as well, and very problematic, and points to again, so you see here, high percentages of respondents reporting sexual violence within the past 12 months, 40%, up to 49%. Despite those alarming data points that I shared with you, we also are seeing some significant achievements. You'll see here, this is just a composition of the number of different FIAs, the population HIV impact assessments that have been released to date from across the countries, and again, the most recent one, Namibia, that was released yesterday. You're seeing that we, together with the countries, are making significant progress toward achieving the 90-90-90 goals. You can see there with Namibia and Eswatini, Lesotho, Malawi, those on the left making really significant progress. We're also seeing, again, from these FIAs, substantial declines in HIV infections in young people in just 5 years. And here on the left here, this is an example of in just 5 years among adolescents, almost a 50% decline in the number of new infections. So really impressive. This has been presented at a number of different sessions. This is data coming out of Caprisa in South Africa. This really shows the key gaps in prevention and treatment services for young men and adolescent girls and young women. And really, we at PEPFAR have focused our investment portfolio to really disrupt this cycle of infection, of transmission of the virus. So really focusing in on what we're doing to make sure that we're finding and treating young men, what we're doing related to preventing new infections among girls and adolescent girls and young women, whether it's through dreams, sexual violence prevention, what we're doing with PrEP, and how we're keeping uninfected young men negative through circumcision, condoms, and PrEP as well. So I'll talk just a second about our VMMC program, and then I'll really focus in on what we're doing related to adolescent girls and young women. This is our cumulative results for circumcision in the number of countries where we work. So at the moment, there are over 15.2 million circumcisions that have occurred to date through PEPFAR support. So it's a pretty extraordinary result, and also we are utilizing program data and very extensive data down to the site level to also make sure that, and age and sex disaggregated, to make sure that our circumcisions are occurring in the most impactful age bands that they should be occurring in. Shifting now and focusing for the rest of the presentation on our priorities related to adolescent girls and young women. So our focus is to really ensure that we are keeping them HIV free. We are supporting through DREAMS our determined, resilient, empowered, AIDS-free, mentored, and safe public-private partnership. We're really focusing on a number of different types of interventions, whether they're structural, biomedical, or community and socio-cultural type interventions. Since it's launched on World AIDS Day in 2014, we are now implementing DREAMS along with adolescent girls and young women themselves, civil society, partner governments across 15 countries in the highest burden districts. As I mentioned, the partnership was launched. We have invested over $800 million in the partnership. And what's really critical is the complementary funding for circumcision and treatment for young adult men in these districts where we're working. This is a busy slide, but really reflects the core package of interventions across social, biomedical, and community types of interventions. And this is just an example of how those interventions translate in a place like Mozambique, where it's age and developmentally appropriate interventions that result in these various outputs and outcomes. To date, we have since it was launched, we have reached 2.5 million adolescent girls and young women through the DREAMS comprehensive HIV prevention programming. And what's perhaps more important is that 65% of DREAMS districts, we're in over 63 districts right now, show a 25 to 40% decline in new HIV diagnoses. We're starting to dig deeper, and this is some recent data. We're starting to see that there are some countries that are doing fairly well in that 100% of their districts are achieving a greater than 25% of decline in new infections. But there are some countries where we're not doing as well, if you see on the right side of the graph there. We're looking at districts down to the district level, down to the site level to really understand what's happening. What we see is that we're not doing as well in urban versus rural settings. And we also know that full coverage of DREAMS interventions, that piece that Dr. Wanjura mentioned, the prevention interventions are truly intensive, and our data are also showing that intensity matters. So going forward, in my last slide here, we are continuing to ensure that we have a long-term investment to focus on adolescent girls and young women. We need to really crack the nut on what's going on in those large urban areas and really understand what's happening there. We're committed to ending sexual violence, following the data that I shared with the Violence Against Children surveys, understanding and investing the importance of secondary education in decreasing incidence of HIV and child marriage. But I think the single most important thing here, and we've heard other panelists talk about this, is that we are committed to continuing to listen, learn, and modify our program based on the data and based on the inputs from adolescent girls and young women themselves to ensure that we're having the greatest impact for their lives. Thank you.
Thank you so much, Anjali. So we're now in the segment where we're going to have the audience open up for questions. And just as a recap, we've really heard from MK all the way to Anjali. MK talking about the tensions between innovation and regulation in condom industry. And Casper really framing the issue and helping us to, I really remember the spaghetti graph that you showed in the, from failing to scaling. And Gina reminding us that the issue is not really the tool, but at the program level. And then Robert and Anjali actually picking up on the same point about needing to actually listen, learn, and change. And that might actually be the prescription that we need for bending the curve. And Wanjiru really highlighting the point, which I think is really interesting, about who leads prevention at national level, and the frequently changing needs of people who are coming for these prevention interventions. So I would like to invite people as I speak to come up to the mic if you have any questions. I also wanted to pick up on the point about risk that was raised from several speakers, but started off by Robert, and that risk is not risky people, but risky situations that happen at specific points in time. So I don't know if any of the panelists, while we wait for questions, want to reflect on any of the points that I just raised. Otherwise, I would ask a question. Any questions on the panel? Okay, so maybe I will just kick us off, or Casper. Okay.
No, I just actually had a question to Gino about the, I think we were just quickly exchanging notes. What I really found interesting was in the San Francisco case that you presented, that STIs remained really low, despite, when taking PrEP to scale. And currently there's the assumption, of course, that we see the latest data coming out of Australia where PrEP has been rolled out and STIs are really going through the roof. And so I was just interesting to hear your views on how that was avoided in San Francisco.
So I'm not probably the best person to answer that question because I don't implement in San Francisco. I think what they were trying to illustrate with the data, and I think it was 20%, right, which I don't think they consider low, was that there was probably no change in condom use even with the PrEP. But again, this was a short time. It was only a year and a half with PrEP implementation. So, but I don't want to say any more because I don't know the program that well.
I can comment on that, coming from San Francisco. STIs are on the rise in San Francisco in terms of diagnosis rates, but they have been on the rise since the mid-1990s. And it was really the advent of combination therapy that first prompted people to use condoms less and to return back to having sexual lives. In the 80s, in the face of all these deaths, people stopped having sex the way they had been in the past. And in the 90s, with a better prospect for living, people went back to sexual practices. But then there was serosorting, which people were choosing their partners based on their HIV status. They weren't choosing their partners based on their syphilis status or gonorrhea status. And then PrEP was just the latest wave in this. What PrEP is doing, though, is it's increasing testing rates for gonorrhea, chlamydia, and syphilis in very dramatic ways. And Sheena McCormack has presented data from the Dean Street clinic experience in London about how really testing for STIs nearly doubled, and the rate of positive tests really didn't change, but the total diagnostic yield was higher. So her conclusion was that, in fact, they had not been testing enough in the past, and that the rates of diagnosis went up just because they were testing more. And eventually, after about a year, the diagnostic yield did start to drop, we think reflecting a real decrease in STIs, not based on PrEP, rather it's based on case finding and treatment of STIs, which is the main way that we try to control them. In terms of San Francisco, the vast majority of the increase we're seeing in syphilis gonorrhea is asymptomatic cases. So we also think that this is due to increased testing rather than increased transmission.
Interesting. Okay, we have a question at mic number 1. Thank you.
Hi, Rivea Miko, University of Michigan. It kind of was just answered, but I think it might be important to just spend another moment on it. should we be looking much more at diagnostic yield versus, you know, the many times we'll see presentations of STI rates kind of going up, but you don't, I don't believe we have a lot of really reflecting on whether or not that's a change in diagnostic yield, and whether or not you think that year that Bob just mentioned, you know, kind of, is there a time period we should be really following the flux in STI cases with the onset of PrEP or the rollout of PrEP before we really start saying, oh my goodness, this is getting higher?
Do you want to take it?
Yeah, I'm happy. Yes, I think that we should be not only tracking the number of diagnoses, but the rate of positive tests among all the tests that we're doing. And we should also be tracking the type of positive tests. A symptomatic case that's identified is probably incident, whereas an asymptomatic case may be just found because you're finally getting to testing someone who should have been tested 5 years ago or 10 years ago. So categorizing the syphilis in accordance with whether it's a clinical case or a latent case is important for interpreting those trends. But ultimately, I think we've spent too much time only using STIs as some sort of surrogate for the HIV epidemic. People don't want to have STIs. They're painful, they're uncomfortable. You have to disclose the diagnosis to your partners. You have to get treatment. The treatment is literally a pain in the ass. I mean, it's a painful injection mainly. And one thing that I'm hearing from PrEP users in a variety of different settings is that they're now starting for the first time ever to shift their focus towards sexual health in general. And they'll say to a prospective partner, they'll say, you know I'm not going to get HIV from you because I know that I'm adherent to PrEP, and you've said that your viral load is undetectable. However, I don't want to get syphilis from you either. And when was the last time you had your blood tested for syphilis, and did you get it treated? And that becomes part of the conversation. I mean, if a gay man tried to have that conversation in a bar 10 years ago, the prospective partner would say, "Are you daft? What are you worried about syphilis for? You should be worried about HIV." And now they're saying, "I am worried about syphilis because I don't want it." And I think our public health departments also have tended to not really focus on STIs except as a surrogate for HIV risk. And that can change and should change. We should care a lot about, what type of STIs people have. Are we optimizing the treatment? Are we really understanding the diagnostic yield in a nuanced way? It's a problem in itself that deserves its own attention.
Thanks. Gino?
So the only comment I wanted to make is I'm glad that you can worry about the issue of diagnostic yield because most of the world doesn't have diagnoses, right? So so we are seeing recent surveys that show much higher prevalence of STIs in the general in the population in general than they used to be, but it's unrelated to PrEP use. It's just probably related to a decreased focus on STI treatment in these countries. So diagnostic yield is maybe an issue for European and U.S. cities, but it's not an issue for most of the world.
So I was just thinking of the ingredients that are necessary to really bend the curve. And we have the data, the tools, the funding, the community engagement, the political will. And I saw in Gina's presentation one of the first bullet maybe in each of the case examples that you brought, the country examples, was around political will. And I was struck also by Anjali's presentation, which talked about structural issues, and all along everyone talked about gender-based violence and all the other things that are barriers at a structural level. So where would you say the focus should be if you had $1 for tackling that structural issue, those structural issues? Deafening silence. Yeah, Casper, then Gina, then Anjali.
I have to steal your mic.
Yeah.
Obviously, I think you get the biggest bang for your buck by changing laws, especially if you look at some of the same-sex relations legislation that exists in parts of Africa and the former colonized world. I think if we talk a lot about political leadership, and I've heard a lot of people speak about smuggling condoms into prisons, for example, and talking to their presidents about smuggling condoms into prisons, getting permission to smuggling condoms into prisons. And the question I always have, if you're the president, why don't you just make it okay to put condoms in prisons so you don't have to smuggle condoms into prisons? I think if political leaders really want to step forward, that's what they should do. They should look at some of that legislation. And I am a bit concerned sitting, for example, at the opening ceremony of this conference the other day, at the amount of times we said political leadership, and the sort of positions being put forward were so liberal, they were so amazing, and so in line with those of my own organization. And I thought, wow, maybe the International AIDS Alliance has become mainstream. And then I remembered, no, hang on, that's not what actually happens. Once we leave here, we go back into these difficult situations and contexts, and we're doing the hard graft still. And those are not the positions that are being discussed out there. You see many political leaders from the global south even come here and speak openly how about the sort of change that's required, but it doesn't happen. And so I don't know if $1 is enough. I don't know if it even costs $1 actually to do that, if for a political leader to simply say no. President to say, get rid of this law.
Anyone else? So Gina, Anjali, and then we'll take the question at mic number 3.
So I think that's a sort of a complicated question, because a lot of the successes that I showed were in the context of laws that were not favorable towards key population. So it's possible, even within those constraints, and most constraints, to do it under a public health umbrella. That doesn't say that laws are not important, because they're permanent. So, and I also think it really depends on what specific risk behavior you're trying to target. So I think when governments are presented with the violence data that was shown by this violence against children, they're very concerned about that. They may not know what to do, but they're very concerned. And so there are probably things that structurally you can do to, and they probably already have laws that address that, and it's just not enacted, right? So that's one issue. I think that, so I think there's an issue of accountability, an issue of data, and an issue of showing progress against these things that builds a little bit of momentum. So I'm not sure what I would invest $1 in, and I agree that laws are important, but it's possible to do things in most settings under the law, under a public health umbrella usually. That's usually how these things get started. So I think you've got to push the laws, but work before the laws are changed.
Thanks. I think that's a great question. And I think, laws, policies are critical. They're absolutely critical. What we've been learning on the slide that I showed with the results of the 10 countries that have thus far performed their public health or their population HIV impact assessments, we are seeing that laws are critical. So those countries in Western Africa, Cameroon, Cote d'Ivoire, where their first 90 is so low, it's because they have issues related to user fees and access with entry into the facilities. So that's just an example. So we've had the experience working with countries where you could put a lot of resource, a lot of money towards something, but if those critical policies are not enacted, as Gina said, and implemented down from the national, provincial, district, and then down to the site level, we're never going to be able to have enough money to make the impact that we need.
Okay, thank you very much. Number 3.
Thank you. I work for a community-based organisation in London, managing a primary prevention service. And I wanted to pick up on one of the comments that Wanjira made in her presentation around how community services are chronically underfunded. And I think it was interesting looking at the PEPFAR presentation when, DREAMS is working in 15 countries. There's demonstrable evidence that this is having an impact on HIV incidence. How, as localized community services, can we demonstrate the impact and the value of our service when a lot of that work is qualitative and doesn't necessarily fit within this epidemiological framework? Thank you.
I wasn't going to answer it for you. I was just going to say, very good question.
It's a great question. And I think maybe there are a number of perspectives from the panelists. So I'll start. I think it's a fantastic question, and thank you for that. we are committed to ensuring, we know that the type of results that we need to see, whether it's for all of the combination prevention that we've been talking about, is not just going to happen in the facility. Community is essential. Community is absolutely essential, and we're looking and investing more and more heavily in community services, community-led organizations. We need to make sure that those services are sustainable and those organizations are sustainable. Our response is sustained over time, and we believe the way to do that is to really make sure that we are focusing more and more on community-led organizations providing those services themselves. So we've been talking throughout this conference, not necessarily in this session, but about our focus moving to more and more local indigenous organizations implementing services and our investment shifting in that way. Again, working with the governments, but particularly with civil society that represent all these people that we're trying to serve. Our services have to be people-centered, AGYW-centered, and we're moving more in that direction.
Thanks,
I'd
Wanjiru.
like to add to that. While I agree, I think when we say communities are underfunded, we need to be careful. It's not just about giving communities more money. If you give more money to communities with the same requirements that are there for other organizations, I think that would not really help. Because, and just to put it in context, you said that a lot of our work is qualitative. It's not documented, most of it. We don't have very good measurement metrics for some of the things that communities are doing. So we also need to invest money in, measuring and presenting that better. But it's also not about giving money and bringing the same kind of measurements that are expected, in the other services, and expecting communities to report them in a similar manner. So I think it's about funding particular areas of work that are underfunded. Not everything in community is underfunded. Like documentation is certainly underfunded, and that's why some of those qualitative achievements cannot be reported, because it's not an area that is very well funded. But also I think it's about listening to communities and what communities are also saying they want to be able to report, so that we are not transferring the same stringent measures of reporting that are in the quantitative into what communities are doing because they are getting more money.
I think we often see that single case reports or narratives of one or two of your clients become really compelling justifications for the services you're providing, and can attract a lot of attention, especially if those are stories well told and they have symbolic value for what is perceived to be a more general problem. So I think that the indices and the metrics are important for large-scale funding, but getting smaller grants can often pivot around a single story well told. So I would say listen to your clients and then tell their story in a way that has symbolic value for your community.
Or Anjali, you want to say something else?
Sure. I was just going to comment about the point around metrics related to qualitative versus quantitative. The question that you raised, and Dr. Wanjiru, you followed up with. I think, we're talking about two things, I think. One is communities leading on the services that matter to the people we're all serving. The other is ensuring that communities or community-based organizations have the capacity, whether it's monitoring and evaluation, whether it's financial systems, whether it's program implementation, but that they have the capacity to deliver these services in the long run. So while the qualitative metrics are incredible and beautiful and rich in that they provide, they could be the one story that makes the difference. I think the quantitative is really critical, and we have to continue to make sure that we're after the quantitative while filling in with the qualitative. But I think both capacity building of civil society organizations as well as direct service implementation is critical.
Sorry, before I hand over to Casper to respond, I just also wanted to just make the point, right, that qualitative data is also data. right? Qualitative data should never be pitted against quantitative data. You should have numbers and stories and numbers. And qualitative data always is told, well, yeah, that's just one story that you can put with the data. But there's proper qualitative data analysis that can be done, and is just as rigorous and robust in making a point in this setting.
Thanks, I would agree with that. Yeah, I don't know how we're going to actually hope to even think about ending AIDS without working with communities. If we think that, let me put it another way. Funding, I think, personally, that we have kind of reached the peak of funding globally at the moment. It's been relatively flat for a while now. And we need to find ways of being better at using the resources that we have at hand. And if we focus on the facility, if we focus all our interventions on the health facility going forward, we will need many more nurses, we will need many more doctors, we'll need many more of everything to really scale things up. And I don't think that we can really truly get there if we don't work with communities when it comes to primary care. But even before we get to the facility setting, there's so much that communities can do exactly around prevention to make sure people don't need the facility, or that less people need the health facility. And if anything, it's the AIDS movement that has shown that. We have 30 years track record of doing this and working with it. We've sort of strayed a bit away from that path, I think, over the last 5-6 years, and I think it's we need to find our way back, because I think communities have so much to offer, not just in terms of cost, but in terms of knowing the context and the circumstances. And I revert to the principle of PHDP, which I thought was one of the most effective and innovative ways of dealing with HIV prevention, which was abandoned somehow. So.
Thanks very much. And maybe I can just ask one last question before we go and see if anyone has an answer to it. So who is this prevention community? Who are the prevention activists that are in the streets marching and demanding for specific things? No one ever likes to answer my questions.
So I'm not going to ask about who are the prevention activists, but I would say that I think when you look at programs in countries, we've lost our prevention muscle. We don't have people who have experience doing it, or the systems in countries where prevention's talked about. So I don't know if you know that there was the HIV Prevention Coalition, which was launched about 1.5 years ago to try to revitalize prevention. And much of the initial work was reconstituting the prevention working group that hadn't met in 3 years. Staffing, finding a staff person to head prevention. So we've lost our prevention muscle, and so I think that's where we're starting in many countries. Not every country, but many countries.
Sure. I think, Solange, that's a terrific question, and I think the point that you raised in a previous question about, what are we doing about policies related to gender-based violence, for instance? I think when I reflect on this question of who is the prevention community, who are those prevention activists, I think we need to be thinking bigger outside of our HIV realm as well, to really think about, the multiple sectors that impact the HIV space, whether it's education, whether it's social issues, issues of justice, et cetera, economic development.
I think I can only emphasize what I said earlier. Prevention is lacking leadership. And where there is no leadership, it's hard to define who that community is. What we have now, in my view, is champions or coalitions around particular prevention programs, like PrEP, or people who are trying to bring condoms back in. But I don't really think we have that. So I'd agree, Gino, we don't have the mass.
So without muscle, we will end right there. So we need some muscle to bend the curve. I think that's what you can take home as your message. Thank you very much for coming to this very big room at the end of a long day, and see you tomorrow. Thank you.